here we have. Okay, again, welcome everyone. As always, we want to invite you guys to social media, be part of our own ecosystem. We are in all the platforms, social media. We have a lot of surprises soon. Ophthalmic University on YouTube. This our channel is incredible. We have more than 5,000 subscribers. So please go there. This video is going to be uploaded after the webinar. So it's the place to go to enjoy all the classes of Ophthalmic University. We want to invite you guys also to the new web. Ophthalmic University has a new web. It's very focused on our courses, so and the campus, of course. So check it out, and it's incredible. A new experience with a new, very fresh website. Of course, we are presenting where we are showing our new campus in Ciudad de Mexico, in Mexico City. So as soon as possible, you can go there and have your training and enjoy the whole experience. I want to show you what's happened this weekend. We will launch in the new Stop and Nothing, these webisodes, 6, all about cataract surgery. So this Wednesday, we will start with advanced pharmacodynamics with Hugo Scarfone from Argentina and Otávio Bisnieto from Brazil. And of course, our host will be Ivo Ferreira. So don't miss it. It's a great session, special session with the in partnership with Alcon Experience Academy. On Friday, we have this amazing webinar. We want to talk about the new challenges in the COVID era for ophthalmology training. So look at this panelist: Susan Pershing from Stanford University, Jorge Valdez from Tec de Monterrey, Gabriela Palis from Argentina, Hospital Italiano, Chris Alabiad from Bascom Palmer, and Melchor Sanchez from UNAM. All of them talking about this new particular era after COVID, how we need to train our fellows, our residents, and of course, with Ivo, we will be talking about the Ophthalmic University hybrid education program and what is the future about ophthalmology training. So don't miss it. It's on Friday, 5 p.m. Mexico, 7 p.m. Argentina. Okay, no more words from Brasilia, our super team from Hub Brazil, Takashi, Jonathan, Daniel. They are on live waiting for us. So guys, I will stop sharing and I will give you the word. Thank you, guys.
Okay, this is great. We're very excited to be part of this once again. This will be one of the first Vivities ever implanted here in Brazil. And we'll be able to have a chance to do this preliminary discussion on this exciting new technology for this lens. So this is going to be pretty incredible. One of the first cases in the world. Now a lot of people are starting to put in this week. So we're going to be part of this new step in IOLs. Takashi, as we know, is a wonderful surgeon here at the Academy. Great teacher. He'll be doing the first surgery, and then we'll be moving. Then we'll be moving on to Daniel Moon, and then we'll be finishing, and they'll chance to discuss the IOL while we're performing the surgery. Good luck then, Takashi.
Okay, hi guys. Well, first of all, I'm showing this case. It's a patient with a 2.0 stigmatism. So we did a arc incision, and since we did the arc incision, it's impossible to do the incision together, the main incision together. So we're gonna do the arc incision with Fento, and now we're doing the main incision with the blade. So this is a 2.2 blade. Okay, showing you here the blade, very near to the arc incision. And since we want to correct the astigmatism and have a very good results for on this Vivity case, because the Vivity case we don't have the torque available yet. So the arc incision we can control And usually we recommend for cases lower than 2 astigmatism. Of course, toric lens is more predictable for these cases. Okay. So usually one incision like the last time, when you do the toric lens, you can do a very precise incision with 0.8 to sub 2 millimeters. So here I'm using a 2.0 incision, and a 2.2 incision is very good already for doing a very good surgery, like using the pre-chop. So in this case, I'm using Asico Pre-Chop. See, this Asico Pre-Chop this is the combo 2. I have the combo 4 available too. So both are really good techniques and instruments. So this kind of pre-chop maneuver really helps us to break the crystalline in many parts here. See? So usually I use a bevel down technique. I'm using the balance tip with the nano sleeve. So nano sleeve is orange and the ultra sleeve is pink. So you can see a little bit different. So this sleeve, usually they are used to 1.8 millimeters to 2.0, okay? So here you can see how precise it is. Catching here. And again. And now I'm using the torsional. Here you can see the shaving effect of the torsional. Very stable. In the follow-up video, you can see very good. See? Femto really, the lens that really helps us, right? Even though this meiosis was done before the surgery, it wasn't after the femto. It really helps to measure. Usually I do a 4.9 millimeters of capsulotomy. In this case, I had to reduce to 4.7, right? So you can see a little bit, you can see the sizing of the capsulotomy after implanting the lens. So here I'm using the curved INA. It's the Asico INA tip. It has like a S shape, and it's sandblasted, so you can do the polishing here, right? See? Okay. So now I'm planting the lens. I do a little bit of a malawash technique, washing technique, and now the lens. Okay. We're centered here. Okay. So very easy to show the lens here. Here, very good. There. So this lens, I did the counter traction technique with the Royale injector, and usually I put the aptics 6 to 12, right? Usually, because I prefer this kind of centration. And you can see very well how it opens very friendly, gently, and it really helps a lot when you can see very well the optics, right? So here we can see the BSS flush sign. Okay, I'll do a little bit of a BSS flush under the lens. Okay, this is a unique technique for aura user. Okay, and then I do a little flush of on the endothelial cells where you have the viscoelastic that is dispersive. Usually the viscoat is very effective protecting the endothelial cells, right? I can see I have a little bit of, you see? And this BSS flush is a technique already described a few years ago on ESRS. Yeah, here, okay. You can see the blocks. So this maneuver can help you to clean it up better. See? Olha bem para a luz. Olha bem para a luz, okay? See? I'm doing a zoom on the optics, see very well. Okay. Okay, guys, that's it. Thank you very much.
Amazing, Takashi. Great surgery. Thank you so much. Amazing procedure. Very, very well. Jonathan, are you there?
Okay, can you hear me then? Let me just stop sharing here.
No. Perfect.
And then I'll share on my presentation. I tried to do the laser here, and then I pressed Takashi to do my laser. That was pretty fast, huh?
Oh my gosh. As Ivo said, Takashi makes everything so easy, looks so easy in his hands. Amazing surgery, Takashi. Congratulations again. I can imagine for the patient. This is so fast, so secure, amazing, so safety.
I'm looking at his parameters here because you see but it's basically a linear vacuum going up to 700. So I think that makes it very effective. Of course, it makes it sound easy, but it ends up helping a lot here. So what I'm going to do, so we can talk, this is a new IOL, and can you see my screen here?
Yes, perfect.
Okay, great. So what we have here, and we're going into a new era in which we'll be able to really customize our surgery. So we've had Panoptix, which is a trifocal IOL, and it gives us near, intermediate, and far distance, and a great IOL. We did the 5-year event a few days ago, but it is a diffractive IOL. So I'm gonna have to keep the mask here on. And this occurs with every single kind of diffractive IOL. You do have some symptoms, glare and halos, and that's because you're talking about a lens that has lines on it. It has the streaks of the diffractive IOLs. It's incredible technology. You manipulate optical elements, and that's great, but you have a scratched IOL. I don't want to use that word, but basically that's what it is. So what we're seeing now, I would like to call it some kind of augmented monofocal lens. And they're calling it X-Wave, as we can see here. And it has a different approach. So they are treating it as an extended depth of focus. So you have an elongated focus, but it doesn't happen due to diffraction. So that is very interesting. What we see here in the design, the mechanism of action, basically, well, the Microsoft platform that I think it's going on to 22 years now. Takashi, want to get a seat over here. So it's been, we've been having the Microsoft platform for the past 20 so years. We see the normal filters. And if you look at it, the surface profile is very similar to an IQ, which we've been also implanting for 16 years or anything like that. And what changes, and this is hard to see on the microscope, is that under large magnification, you see the X-Wave technology, which is similar to a plateau that is located in the center of the IOL. Now you have a certain elevation here, but this elevation is smaller than 1 micron. So you have this change in the center of that lens, and it is about 2.2 millimeters diameter right in the center. It's a very subtle curvature change. And the whole idea is to promote a shift in the wavefront rather than splitting the optical elements that usually occurs in diffraction. So that's how it works basically. Here we have an optical lab diagram of how it's supposed to work. So you see the convergence that occurs. You see the convergence that occurs in any standard IOL. But once the wavefronts or the light itself passes through the center of the lens, then what you get is an extended focus. So it's different from other extended depth of focus IOLs in the sense that it doesn't use diffraction. So they're calling it a surface transition, an element. It stretches the wavefront, shifts it, therefore promoting a simultaneous action at a distance vision and also intermediate distance. We don't have the video here, but what we see is a change in the basic curvature using a non-diffractive technology. So this is going to be very interesting to use with the panoptic IOLs or in situations in which you're not allowed to use diffractive IOLs. So I'm thinking of any kind of retinal change, any kind of corneal change. But in reality, any patient that is a great monofocal IOL patient, and then we'll be able to introduce this augmented technology. And here we see comparison to other extended depth of focus, but here we see the optical profile of the Vivity IOL down below here. So I think it's a very interesting lens here. I'm going to have to go through the presentation because this is very fresh. And what is Takashi on the next discussion will be able to go through the extended depth of focus because that's his expertise. But what is interesting here is the halo profile of the Vivity and a standard Acrosoft IQ that we see here on the left. So very similar halo profile. So I think we're moving to a type of IOL that brings us great distance vision, brings us intermediate vision without changing the distance vision. And that I think has a lot of potential. I think Dr. Daniel will be starting right now. I'm going to hook him up in the audio. He'll be able to talk to you soon. But I'm really excited and I really want to see our personal results with this type of IOLs. The speakers that have shared their experience with us have had a very positive experience regarding this. So this is very interesting. I'm going to leave it here at this image. And I'm going to hook up Dr. Daniel Moon and share his video right over here.
Perfect. Thank you, Jonathan. What excited technology, right? I mean, amazing. For our patients, I think would be great. So Daniel, it's ready for another live surgery, guys. Thank you so much, Jonathan, Takashi, Daniel. You are on live.
Hello, good morning. Can you hear me?
Perfect, perfect.
Thank you. Good morning, everyone. I'm Dr. Daniel Lee, and I'm going to perform another surgery, live surgery. I always say that it's difficult to replace Dr. Takashi and do a surgery just after him, but I'm trying to do my best, okay? I use the lens X, and in this case, the patient is a 58 years old female patient, and she has a 1.3 astigmatism at 90 degrees. So I did my main incision at 90 degrees and an air-create incision of 25 degrees at 270 degrees of axis. And I did my secondary incision here too. I usually open the accessory incisions first. And then the main incision. You open easily. Then the first thing I do is inject intracamera anesthetic. It hurts a little bit in the beginning, but helps a lot during the surgery. We saw here that we have already a free float capsulotomy. Olha pouquinho mais para baixo na cara. Isso, perfeito. I like to put viscoelastics over the cornea. And now we have a free float capsulotomy here. Very easy. Só abrir aqui. And I'm opening the secondary incision right now. After taking off the capsulotomy, I take off a little bit of the viscoelastic and perform the hydrodissection. And we have to be a little bit careful because in femto case, we could have a lot of bubbles behind the lens and between the lens and capsular, the posterior capsule. Not in this case because this cataract is soft, so we didn't have a little so much bubbles. But when we have it, we have to take care and take it off. Then I replace a little bit of viscoelastic. Again over the cornea. And differently from Dr. Takashi, I always use both hands. I always use my left hand in the accessory incision because it helped me in my technique. I'm taking off the bubbles here. And my technique of choice is Asico Chop. I'm trying to rotate the nucleus, but it's already detached. So we always have to aspirate the nucleus here. Practically without ultrasound, just aspirating it. Very soft nucleus. And we are performing the aspiration of the whole nucleus and cortex. Okay. We almost didn't use the ultrasound. Bota no cortex para mim. And olhe na luz, por favor. Before aspirating the residual cortex, olhe para baixo um pouquinho. I always try to do the second wave described by Dr. Jonathan Lake. That is a second hydrodissection. We had a perfect here because it helps in the aspiration of the residual cortex. Olhe para baixo um pouquinho. Isso. Para baixo. Ótimo. So it's very easy to aspirate the residual cortex because the second wave detached it almost entirely. Okay. I always like to polish the inner part of the anterior capsule too before placing the intraocular lens. And I always do a power wash. You can inject the BSS against the posterior capsule and polish it without touching it with instruments. We have very good tips of aspiration tips that is very safe, but I think nothing safer than doing it without touching the posterior capsule. I perform the aspiration of the residual cortex here. Behind the incision is the most difficult part and the most dangerous part, so you have to be very careful too. Olha para mim, por favor. So we have the lens here, the Vivity lens. Is the new intraocular lens of Alcon. Is classified as a EDOF lens. We can see in the center a little kind of rings. Actually, they say that these lenses don't have any rings, but we can see in the center, in the very center, two zones, a central zone and a peripheral transitional part of the lens that allows a better intermediate vision. So let's implant the lens. Olhe na luz, por favor, Natália. Olhe bem no meio da luz. Ótimo. I like to use the Royale injector too. I use this injector for all my lenses. Okay. And I like to do the counter pressure technique too.
Takashi, can you hear me? We have frozen the image of the microscope. Can you see that?
Congelou a imagem? Is it frozen?
Yeah.
You didn't see the implant of the lens?
Okay, now, okay, perfect. Now we can see it.
Okay, you can see?
Yeah,
Did you
yeah.
see I'm showing the lens outside the eye?
No, now.
No.
In detail. The center of the lens.
Yeah, I showed the lens outside the eye. If you didn't have the images, Dr. Jonathan can show you in the next surgery.
Yes.
So
Because
I implanted the intraocular lens. Is very familiar to us. Is a yellow intraocular lens, very similar to IQ lens, Clarion, and we are so familiar with this platform. So it's very familiar, usual, and easy implantation for most of surgeons. I always like to go behind the intraocular lens to aspirate the viscoelastic. You have a little. And then we center the lens. Olha bem no meio da luz agora. Okay. At the end of the surgery, I like to hydrate the side of the main incision. And the secondary incision too, a little bit. Then when we are using a special lens, we have to take careful of the centering of the lens. So usually I ask the patient to see right to the light. Olha bem no meio da luz. Okay. And to finalize the surgery, I like to use intracameral antibiotics, Vigamox. So that's my surgery, and thank you, everyone.
Amazing performance, Daniel. Thank you so much. It was incredible, incredible surgery. Thank you.
Thank you so much.
Can you hear me, Takashi?
Okay, Takashi here.
Awesome.
Listen. Okay, can you see here the graphics here of the clinical?
I can see it. Perfect.
Okay, so Jonathan was talking about this intermediate distance evaluation of the Vivity. So this is an Alcon data for the FDA. They did a global and a US study. And you can see by the reading speed of the font size, right? He maintains between 20 to 11 size of the words, the size of the font size of the reading speed. So the aim goal of this technology is the 66 centimeters intermediate vision. So this is the global and the US trials results. You can see some very similar results where they compare Vivity IOL with Acrisoft IQ. And you can see the advantages on 66 to 40 centimeters. So this chart shows visual acuity in logmar from 66 centimeters, showing 0.1 logmar. So it means the vision for 66 centimeters is stable. And the aim goal of doing the intermediate vision between 40 to 66 is because of the way of life, right? The forgiving and flexible defocus curve for delivering intermediate vision and hitting refracted targets that has a kind of a continuous extended range of vision, especially for this distance where you use your computer, your iPhone, your phones, or television. And this technology is exactly analyzed binocular, always binocular. So this is a binocular defocus curve. Of course, scientific papers, you can evaluate monocular and binocular a little bit different. And here you can see a comparison between other lens. So here is the Acrisoft Vivity and the Symphony, and comparing the visual disturbance for these two for these two kind of IOLs. And you can see that both IOL has a little bit of a different design, and you see the Technis monofocal and the Technis Symphony has their difference, and the Vivity and the Acrisoft IQ has their difference. So the main goal of the intermediate vision is really has some points to have to have less starburst or halos or glare than multifocal IOL. So this is the profile comparable of Acrisoft IQ for Vivity, comparing the starburst, the halos, the glare, the hazy vision, the double vision, the dark area, the blurred vision. So you can see there is a difference between both IOLs, but like they say, the person or the patient is not bothered on these cases. And especially for the new designs, comparing from the old designs, the reported of visual disturbance, of course, is the aim goal to have good results and satisfaction of our patients. Front. So this is the Acrisoft IQ Vivity patient reported visual disturbance profile comparable to IQ, using if they are bothered by the visual disturbance. So in this case, we say a little to very. So you can see a little starburst, and a little halos, and a little glare. Almost no glares, right? Very glares, very low. So when you compare both groups, you see it's very similar. It's because the starburst is very related to PCO, and halos and glares sometimes with the residual refractive errors. So these combined problems can give a mix of starburst, halo, and glare. Oops. Let me see here. Okay. So this is a kind of a validated questionnaire that we use to evaluate these photopsias. So here you have a chart with different grade scores of dysphotopsia. So on the picture, you can see none, a little, mild, moderate, and severe. So the patient can answer by the picture. So on this is a validated questionnaire. So the patient will know if it's really how often it is. It's never or rarely or sometimes or most of the time or always. And so here you can see that this lens is focused on less disturbance, especially for dysphotopsias. Okay. So pupil size, as you saw, Daniel Moon showing a 2.2 millimeters of different design on central part of the IOL, especially for giving the intermediate vision. So pupil size should matter if it's less than 2.2. But usually, in these cases, patient has more than 2.5, especially in photopic conditions. So here you can see the best correction distance visual acuity, right? And the distant corrected intermediate visual acuity and the distant corrected near visual acuity. And you see about the how the pupil sizes doesn't matter so much, and has a very similar evaluation results from IQ, Acrisoft, especially at the small and medium size. But for near and intermediate vision, you can see there is the advantage of the Vivity IOL. You can see that, especially for intermediate and near vision, you can see the logMAR is better for Vivity group. So this is the maintenance of the distance that we just said about the intermediate and the near vision and the distance. So the advantage is to offer exactly 66 millimeters, especially for the computer or the phone distance. So the computer is 66 centimeters and the phone distance for 40 centimeters. So remember, this is not a multifocal IOL, so it means that 0.2 logMAR for 66 centimeters. Okay, and it's a 0.39 and 0.25 for so 0.25 for Vivity for near vision and 0.05 for 66 centimeters. So I would say that the aim goal for Vivity is 66 centimeters for the patient, and focus on intermediate vision. So I think the key inclusion of this. Oh, okay. Now Jonathan Lake is ready, and okay. Let me just share here the screen. Okay. Can you see there?
Yes, perfect. Jonathan, if you can just remember to show us the lens, that would be great, because with Daniel, we have a frozen.
Stuck.
Yeah, exactly. Frozen image. Awesome.
How beautiful the lens, the incisions here are with the Lens X. They're pretty incredible here. Now, with this type of pattern, which is a full frag, I think it's easier if you visualize all the structures here with Tripon Blue. And then here we're seeing it, and let's see how the rexus is behaving here, and see if it's nice and free floating, which it is. And I can go straight to the hydrodissection right over here. You can see it nice. So we can do this all in one nice maneuver here. A bit of the hydrodelineation. And this also has a little bit of lidocaine. That helps with the comfort of the patient. So you guys saw the pre-chopping here, and I'll do my favorite technique, which is a pre-slicing, in which what changes is that we go from the periphery to the middle. So we enter here. It's very important that we're here in the cortex. Also here in the cortex. And we can see that this is a harder nucleus. So it allows us for separation for these harder nucleus here. And then we can see that the rest is nice and mobilized. So I'll get the, just a little bit off position here for me. Just let me know if it's nice and centered. Parameter wise, Takashi went with full 700. We don't have an overlay here, but linear. And this is a 500 but fixed. And here we follow the same standards here of conquering. I will try his parameters though. Important that we get the rexus right over here. See, it's coming out through the incision. And then we'll proceed to conquering these small fragments that were created here that we can see. Okay, so we proceed to half of the nucleus right over here. We'll go with the second one right over here. I'll just hand over my chopper. And I think you can open up. Você pode abrir a lente já e pegar meu chopper? Pode pegar meu chopper, por favor. Da minha mão esquerda, por favor, você pega. Okay, so we're going to the final steps here. Well, almost the lesson. Just mentioning that I want to show the IOL. Now let me know if it freezes, okay? Because then we'll tell Takashi right over here and let it go. So as we commented here, let's see, I've been on a nice streak here with the second wave. Let's see if we can free the cortex. Now, this is a very thin cortex here. So we can see that it's already, there wasn't any real attachment to it. So I'll just go through standard aspiration. I would say the second wave usually occurs about 60 to 70% of the times we're able to do it successfully. If there's like you see a space created within the cortex here, then it doesn't finish. Even though it is a good maneuver to mobilize. What's on a PA? Você tem sem lá? What's that PA? Okay. Are you guys listening to me? Can you hear me at all, Andres? I'm here on the earphone. I haven't been getting any feedback.
Everything is coming. John.
So what we see here is a thinner cortex. So there wasn't really a pathway for the second wave right now. This is a great sigmoidal irrigation aspiration device, coaxial, and it allows us to go right underneath the incision here, and we're able to get this cortex over here without great distortion of the incision itself. We can see that it still is a little bit more adhered than what we see in standard. So since I don't want to, so since I don't want to distort the incision here, what I'll do is I'll get a cannula that will help me aspirate by using the paracentesis. And then that'll help us clean up the last part of the cortex over here. So I can get right in this without really losing any anterior chamber. This is a very good device. I think it's the first time we've been using it here, but it's a good demonstration. It's always good to have this inside your equipment. Always a know-how. And here we get the last piece of cortex. think this is it. Okay. I like to, even though give a little bit of, do a little power wash, mala wash, we call here in Brazil, because of Malavasi that has, he's also a colleague of the Ophthalma University. And okay, let's spend some time looking at the lens here. I'll move this, focus it here inside its cartridge. And it's very subtle. Look, if you look at it like this, it's very similar to an IQ. It's hard to tell the difference. But then we can see the ring here now at this inclination. Can you guys see it?
Oh yeah, yes, we can see it.
This is very subtle here.
Mm-hmm.
Let's see if I can maybe zoom in on it here. Okay, there it is. It's a very subtle profile in the middle here. You almost have to really see the difference in shining here. But I think it was registered. I think we'll be able to, for those of you that are watching it on YouTube, we'll be able to see it pretty well. And then we'll have another look at it inside the eye. But this is a level of magnification, so over 7 in order to be able to see this. Acrosoft. Acrosoft has been over 20 years. It's a really, well, it's a basis of the platform for most IOLs. The design really is a winning design for the capsular bag. So this is really great. No, hold that. Okay, so let's just use I like to mobilize here since we're using okay, she's moving a bit. Let's just get this in. Okay, nice and slowly, but then we have to kind of increase speed a little bit so it doesn't get stuck within the incision. It's one of the things that not impossible to happen, but with a 2.4 incision, we're able to use the standard D cartridge, and that really makes it easier for all of us. And then we'll just fit it in. So you see how it glides nicely into the capsular bag. We'll give it a little bit of help here with there we go. Okay, now I think during aspiration, you'll be able to see the ring showing up a little bit once in a while I do the capsule polishing here. I think with every single piece, we have to go, like Daniel said, underneath the lens. Takashi, I'm going to spoil it a little bit, is going to send a great video to the ACRS that demonstrates how we can push out the viscoelastic from underneath the lens. Okay, do you see the ring right there? Look, it has to be at a very small angle and then it shows up. There you go, see? There we go. I think we got a nice vision here, right in the middle. Very hard to see this. So it really is a tapering of this lenticle on the inside here. And I'm really excited. I'm really looking forward to seeing with the whole manufacturing system that Takashi has here to see our the incision is nice and sealed here. The great thing about femtosecond incisions is that they're really self-sealing. So we'll go in here with a Vigamox, prevent undophthalmitis, and here we have the last scene. Okay, guys, great seeing you guys here. This has been really special for us to perform a live surgery. In this format with Ophthalma University, this has been fantastic. I think it's really working out great for all of us, and we have a chance to share our first time experience with everybody here in Latin America.
Amazing. This was historic. Thank you so much. What a great surgeries. What a great event. First time in Latin America. Thank you so much. Opti Group. This is an honor for Ophthalmo University. What about the experience with the IOL guys? What can you say about it?
This is our first.
I
This
know.
was our first 3 cases. So let me get this.
So this is great. This is great, and you make easy everything. Amazing.
The first time, no, the lens is exactly the same as any other Alcon lens, right? So you guys see any difference? This was literally our first 3 cases, first 3 cases. The group, first 5 cases in Brazil. I know a couple of friends of ours put some of them in.
Amazing, and we had the honor to have you guys on Ophthalmo University with these surgeries. For me, it was incredible. These surgeries, this event will be on YouTube right now in a few minutes. I don't know if you want to say something else before we leave.
I think this is great. Nice short procedure, right?
Yeah, exactly. On
We all
time.
enjoyed it.
1 hour,
1 hour
event,
for 3
right?
surgeries and talking on the presentation. We're looking forward to the next presentation with our results, right?
For sure.
Absolutely. We need to do this more often with you guys. The 3 are amazing. What a great surgeons you are. I'm thinking all the residents and fellows thinking about, okay, I want to be with them, learning, FACO, and all these things. Amazing, guys.
That's great.
Thanks so much.
Everybody's welcome to visit us here.
Okay, thank
See you
you.
later.